got them done this morning. So.
I was just lately late. Back for last year. I literally can't.
Yeah. I feel like we're not even
talking about anything. Like, you just went on and on and on. And I'm like, what is your point?
I feel like what we're learning in class is not relevant to what we're supposed to do.
We are, though. But they're still like, and I don't get why are we still doing Miller quizzes if when we tell them we finished Miller, we're just getting 100%.
Yeah, I know. I thought he told us we're not.
I know, he told us we're not, and then the next day we were doing Miller quizzes again. I don't understand. Exam was supposed to be up last week Monday, and it's still not up.
And the fourth exam is going to be next week.
I'm like, he said something, I'm like,
I sent him 2 book summaries and I have not heard back.
it took him a hot minute to get mine back.
I sent my first one like 2 weeks ago.
Really?
Like, if I
I
mean, I've emailed them like 4 times and I've never heard back.
Very serious.
Yeah.
What if something says he's going to do something like he needs to start doing it? He's like, oh, we can't just get. And then here we are a week later, and it's still not up. I'm like,
I always wonder what you guys say about me when you're in my class.
I'm just gonna know.
You don't say anything when you're actually.
I just like. He told us.
Well,
Not last week Friday, but the Friday before.
Corinne,
the exam was gonna be up by Monday.
I agree with you. Just keep in mind we're fallible and we forget.
But like it's been over a week since he said it was gonna be up. And like our next exam is on Friday. And he hasn't even put like one before that up.
No, you're right. If they say they do something, they should
And then
do
he
it.
says
I agree.
that we're not gonna do Miller quizzes anymore, but we still do Miller quizzes. It makes no sense. Like don't tell us the exam's gonna be up if it's not gonna be up.
Miller's a type of beer as far as I know.
I wish that's what he was talking about. It's like a book. You see all the functional errors when you do it. Drives me nuts. Oh, it drives me nuts. Like every other word is wrong.
Meredith, can you hear me?
Yes, I can.
Okay. Is that better? Can you hear me better now?
It sounds about the same.
About the same? Yeah, hang on. Okay, is that better?
Yeah.
Okay. Okay, that should be even better. Okay, we're gonna get started here pretty soon.
What is our exam on next week Monday? What chapters are
10, 11, 12, 13. 10, 11, 12, 13. 10, 11, 12, 13. So as the lovely Miss Corinne. Oh, there's Corinne. Nothing. Uh, reminded us we have an exam a week from today, the 16th. First of all, are there any conflicts with that day you need me to know about?
There's nothing wrong with Bible having.
Not to the best of my knowledge. Meredith, Jess, any conflicts for the exam next Monday?
I don't think so.
I think I'm good.
Meredith, you're good? Okay. The exam will be the same format as last time. 50 questions, multiple choice. I will try as best I can to get a practice test together and email it to you. I don't know when. This week is pretty nuts, but I'll try. And yes, you may remind me, Corinne.
Just don't give me a day and then not have it up on
No, Corinne, I appreciate it when you remind me, actually,
my. Okay, I will.
I forget stuff. So no, you go right ahead and remind me, okay? You're quite good at that, actually. I appreciate it.
I'll do that.
Okay. You remember dates really well, I've noticed. Yeah. You'd be a good event planner, probably. You are a good planner? Yeah. Was it? Oh, exam. So the exam next week, 50 questions, same multiple choice and true false, just like before. All right. Our lovely ladies on Zoom, will you be back in the saddle by then or no? Or do you know?
I will be.
I will be too.
Okay, then we will look for you in class. Otherwise, you'll take it in the Academic Student Connection, ASC. I believe she is, yes.
She was in physics 20.
Well, things change. All right, let's go ahead and have a word of prayer. So two things, well, three things actually. I don't know if you guys heard, but sixth grade teacher over at Warner passed away this weekend suddenly. And some of the faculty have kids who are in that class. The thing I liked about Brad Lenhart, when many elementary school teachers run away from science, Brad grabbed science with two hands and squeezed it very tightly. He was very pro-science. He did a good job. Didn't always have the best classroom control, but he liked a very active, noisy class. And sometimes those are the kind of classrooms where lots of good thinking, lots of good experimenting go on. And he was always willing to have Tom come over. He was always willing to have me come over and do stuff. If I had frogs, he'd take the frogs and they'd do dissections with the kids. So that's a big loss. So some of those kids are pretty shell-shocked. Those teachers and aides are pretty shell-shocked. Secondly, I had a Bible quiz this weekend and my team got disqualified because one of my quizzers cheated. No, I'm not kidding. I am serious. So this next practice, we're going to have a very long talk about integrity. The other quizzer was thrown out too. At first, I thought that was harsh, and then I said no. She needs to know that her consequences affect other people. She also needs to know that we have a zero tolerance policy. I hope you do too. I hope you have a zero tolerance policy for cheating for the rest of your life. Jesus said in John's gospel, he said, if I testify about myself, my testimony is not true, but there's another who testifies about me, and his testimony about me is true. You have sent to John, and his testimony is true. So Jesus was very big on the truth. So pray for my quizzer, because I get to lower the boom. And I don't like doing that. I want to be more encouraging, but I have to. I have to. When you guys become parents someday, most of you in this classroom will, you'll have to lower the boom, and it sucks. It really sucks. So, yeah. Last thing, Friday, seminar. So Tom Kunzelman and I are talking about COVID-19, masks, flasks, and tasks. And we'll talk about some experiments, and we'll talk about some epidemiological data. The goal is to be practical, ways to lower our risk here in Michigan and at home. Yeah, that's one way. But I hope, keep in mind, we can only have so many people at White. If you want to be there in person, you have to pre-register. Also, if you want to ask a question, please pre-submit your question, because passing a microphone around is not a good public health practice this time, at this point in time. Okay, now we will continue. Lord, thank you for a nice warm day. Thank you for the students here. We pray for those in quarantine. Lift their spirits up, keep them encouraged. Thank you, the Lord, that you've given us this great weather now. Help us proceed forward. Help us honor you, the source of all truth. In Jesus' name, amen. So we looked, let's,
I got a question about the seminar.
yeah,
Is there a Zoom link available?
there will be. I will make it, and Mrs. Schaefer will advertise it. Very good. So you can see here that the adaptations to exercise are extensive. There. So the increased activity of the skeletal muscle will cause the production of lactic acid. This very simply comes from the oxidation of glucose. That is predominantly the case with your type 1 fast twitch muscle. So the type 1 fast twitch muscle has very little myoglobin, relatively few mitochondria per gram, well, actually per cubic centimeter of muscle. It's very dense. It works by essentially, it stores glycogen. It hydrolyzes that glycogen. It burns it via glycolysis. When it gets to pyruvate, however, it converts that pyruvate to lactate. The muscle cannot recycle this, so it has to send it through the blood to the liver. So the muscle says, liver, take thou my lactate and be blessed. And the liver will use this for gluconeogenesis. And it will use it to make glucose. And that glucose will then be usually stored as glycogen. Or it might be released back into the blood. Depending upon which hormones are in the ascendancy. So that lactate is going to cause the pH of the blood to drop. And there are peripheral chemoreceptors. And these peripheral chemoreceptors these are in the aortic arch. And they're in the carotid body. Now, if you don't remember those structures from A&P, review them, please. I won't take time to review them here. So when these specialized neurons detect the drop in pH, they fire more frequently, and this will notify the respiratory centers in the brainstem. And this signal to the brainstem respiratory centers is going to increase respiratory rate and respiratory depth, and that will produce this phenomenon commonly known as hyperventilation. And this is something you may have observed if you're doing powerlifting. In order to gain strength, you're not moving a lot, you're not running a lot, but boy, are you huffing and puffing a lot, because that intense muscle activity is producing a good deal of lactic acid. That causes your breathing to go up. So you get done with maybe even just a few reps at very high weight, put that bar down here, even though you really didn't move that much. Your Fitbit doesn't tell you you did a lot of steps then, but boy, you're breathing hard. That's lactic acid production. So more air reaches the alveoli. That is going to cause pulmonary vasodilation now. Pulmonary vasodilation. That reduces pulmonary vascular resistance. That's why I really wish they had the lungs on here, because blood flow to the lungs goes up during exercise. So you get increased pulmonary flow in all three of the zones of the lungs, the upper, the middle, the lower, all three. So you have increased pulmonary perfusion, increased pulmonary perfusion. And the number of alveoli not being actively used goes down. The so-called physiological dead space, that goes down. And so gas exchange will increase. Okay, now, at the same time, next thing also that happens is you have the so-called tractus solitarius. Tractus solitarius, and that has that receives signals also from these peripheral chemoreceptors. And that, when stimulated by the peripheral chemoreceptors, which we just say little PC on it, that's how polymerase chain reaction as peripheral chemoreceptors. This is going to increase sympathetic input to the heart and decrease, you guessed it, parasympathetic input to the heart. So what happens to the heart rate? So that's why if you get on a treadmill, and I'm betting, Ram, this doesn't happen to you because you're a distance runner, your body's working more trained not to do this, but you start running just a little bit, and in anticipation of that, your heart rate jacks up quite a bit before you actually really get going. Now, trained distance runners, like Ram, I'm betting, you probably have to run a bit before your heart rate goes up over time. If you put me on that, my heart rate's going to go up. And that essentially is also the result of these peripheral chemoreceptors sending signals to the respiratory and the cardiac centers at the nucleus triphus. All right. So, increased sympathetic input does something else. Different color here. That's going to now go to the adrenal glands. And that will cause the release of epinephrine and norepinephrine. And as I get to the bottom of this board, my handwriting really starts to degenerate. It wasn't that bad, wasn't that good to begin with, so hieroglyphics. Now, this is going to reinforce the effects of the sympathetic nervous system on the heart, isn't it? It is also going to cause bronchial tube relaxation in the lungs that will further increase your gas exchange in the lungs. It also causes dilation of skeletal muscle blood vessels and constriction of peripheral vessels. So you're essentially taking blood where you don't need it, like from the gut and skin and other places like that, and it's redirecting it to skeletal muscles. So you get vertebral vessel constriction. What are the receptors that mediate that? Alpha 1. Alpha 1. And then you also get skeletal muscular vessel dilation. And what vessels mediate that? Beta 2. Beta 2. So you get skeletal muscle vessel dilation. That is mediated by the beta 2 adrenergic receptors. Now, these chaps are going to run out of glucose, aren't they? Gotta feed the fire. Gotta prime the pump. Gotta throw another log on the fire. Gotta, whatever. Feed the beast, whatever. So epinephrine in combination with glucagon. These are going to tell the liver to degrade its glycogen stores and release them into the blood so that the muscles now have fuel to be able to work. So, glycogen, glycogen is degraded to glucose. Glucose is released into the blood. And now this can be used as fuel for the muscle. Now, this increased blood for the muscle. This is a phenomenon called functional hyperemia. Functional hyperemia. Taking blood elsewhere, giving it to the muscles. And then glucagon also is going to stimulate the breakdown of fat as well. That will give you fatty acids. Fatty acids will feed the other tissues and spare the glucose for the exercising muscles and the brain. And this is one of the reasons why exercise can help you lose weight, because it will stimulate lipolysis to feed the other organs. The heart, as a result of extended exercise, will start to thicken the walls of the ventricles, and this is called compensatory cardiac hypertrophy. It's different from pathological cardiac hypertrophy. And this is the reason why I keep picking on Rem, but he's a good sport about it. If we stick Rem on an EKG machine, I'll bet you his QRS wave goes way up high. And that is thickening of the heart because of exercise. And when the cardiologist sees that, if it's pathological, you're going to get that, but it's going to be in a large QRS. With Rem, I'll bet you it just goes like that. It's pretty high. And that is a functional cardiac hypertrophy that is compensatory for exercise. All right, now, what are the places in the heart where these sorts of things have their effects? So first of all, the SA node, as a result of sympathetic input, you have decreased rates of diastole. You have increased rate of diastole and depolarization, and you increase cardiac rate. You also increase the strength of contraction. We'll get to why that's the case here in just a bit, but that's something peculiar to the sympathetic nervous system. Parasympathetic input does not affect the force of cardiac contraction. Sympathetic input increases the force of cardiac contraction. The effects of the sympathetic nervous system are not just limited to the SA node, they also extend to the AV node. You get increased conduction rate through the AV node. And you have increased conduction rate through the ventricles as well. Not huge. Most of it's actually here, but you get increased strength of contraction. That's a big one here. And if you have that slide in front of you and you have a highlighter, you might want to highlight that one because that's unique to the sympathetic nervous system. Now, the parasympathetic nervous system tends to affect SA and AV node, doesn't really affect the muscle much at all. So you get decreased rate of conduction and decreased rate of systolic depolarization, diastolic depolarization, and decreased cardiac rate. So as we said, the two catecholamines released by the adrenal medulla are going to increase the rate of firing of the SA node. And here's how they do it. We'll just go to the next slide, then we'll come back. So here is that pacemaker potential I told you about. This is due to the HCN sodium channel, the hyperactive to cyclic nucleotides. Here's what happens when you give it epinephrine and norepinephrine. What do you notice here as opposed to here? Yeah, it's a lot steeper. Reason for that is that those channels, when they are bound by cyclic AMP, they open much more readily. They're hypersensitive to cyclic nucleotides. So you get the depolarization occurring much like you do here, but that pacemaker potential is much steeper. That's how you get the heart to beat faster, when you give it these catecholamines. And remember, catecholamines bind to beta 1 adrenergic receptors. They increase the intracellular concentration of cyclic AMP. That's what's influencing these channels, is cyclic AMP. Now, what about, let's go back now, acetylcholine. That is a neurotransmitter from your parasympathetic nerves. They're going to hyperpolarize the SA node. They decrease the rate of firing. They bind to muscarinic channels, specifically in the heart M2 channels. Those M2 channels will decrease cyclic AMP levels in the cell. Because they decrease cyclic AMP levels in the cell, now look at that pacemaker potential. It's really pulled down. You might notice this after you have a good meal. Your heart rate is actually a little lower than it usually is at rest, because now the parasympathetic input is increased because the parasympathetic nervous system is so active in your GI tract that your cardiac rate slows down, and that might be a contributor to getting tired after a big meal. Also, people who have this condition called angina, where their oxygen levels dip in their heart muscle, so they get pain substernally in the chest. They tend to get that pain after a big meal, probably because the heart rate slows down substantially, so they don't get proper circulation through the cardiac muscle. Yeah. Yeah, usually for a big meal, unless somebody has really severe angina, in which case, or if they have so-called atypical angina, certain foods may cause it to happen. There's something called princemental angina, where the cardiac muscle spasms, and that can happen just randomly, or certain things can set it off, and that can, certain foods may cause that. I had a teacher in high school, garlic would cause him to get chest pains. That had happened since he was very young, and he couldn't eat garlic, and I just can't imagine a life without garlic. So bland. Yeah, anyway, I love garlic. Garlic makes the world go round as far as I'm concerned. Can I get a Croatian amen? We cook with a lot of garlic. We love our garlic. All right, so we looked at ETV already. Total peripheral resistance. Total peripheral resistance. That has to do with the resistance against which the blood, the heart is pumping. So that's your systemic, the resistance of your systemic circulation. That is usually going to be due to the arteries. The arteries. You know what? Let's leave the equations out of this. You guys have physics. You got enough equations. Think of it this way, though. If this comes out of the equations, which will give you more resistance, a vessel that's this big or a vessel that's this big? Smaller one. And you've seen this probably when you're watering your garden. If you want the water to shoot further, what do you do with the hose? You decrease the aperture, and now the flow rate gets a lot faster. So the resistance is going to be dependent on the diameter of the vessels. So vasoconstriction tend to increase resistance. Vasorelaxation will tend to decrease resistance. Contractility, that's the strength of the ventricular contraction. Strength of the ventricular contraction. So resistance, I think, can be easy to think of if you consider something flowing through a tube. Might as well just do great form here. Blood doesn't act like water acts. It's more viscous than water, but it's not like ketchup. So it's not a non-Newtonian fluid. It does flow. But if you're in a tube, this is going to flow pretty freely. This here, it's interacting with the vessel. And so you're going to get drag forces at the edge here. Same thing here. Because of that, if we looked at the flow rate, it'll kind of go like this. Towards the middle, and then more towards the edges. That pressure that's exerted on the walls of the vessel, that essentially is blood pressure. And that resistance that you experience, that's your total peripheral resistance. So that's an impedance to the ejection of blood from the ventricle. And this is what is referred to as afterload. Afterload. That's the force that the ventricle has to produce in order to pump into the vessel, resistance and all. That's afterload. Now, there's another term that's used in cardiac physiology, preload. And you guess what that is? Yeah, that's essentially the load that you carry over from the last contraction. That's there, that'll be added to the afterload. And that is usually essentially what's left in the ventricle. Usually, that will depend on venous return, and it depends upon the force, essentially, of the contraction. This is important clinically because some drugs reduce afterload, some reduce preload, some reduce both. So the proportion of the end diastolic volume that gets ejected against this peripheral vascular resistance, against that particular afterload, it depends entirely on how strongly the ventricle contracts. So the strength of the ventricular contractions, they'll go up as the end diastolic volume goes up. And man, that's very, that's just better. Yeah, it is from here. If it's worse here than it is out there, just the glare is awful. So the rate is dependent, of course, on input from sympathetic and parasympathetic nerves. And then the sympathetic input influences the contraction strength. Then the mean arterial pressure the heart spends 2/3 of its time in diastole and 1/3 of its time in systole, right? So then this is equal to 1/3 of the systolic blood pressure plus 2/3 of the diastolic blood pressure. That's mean arterial pressure. You can also, through some cool math, you could actually say that the MAP will also be equal to the diastolic blood pressure plus 1/3 of the pulse pressure. You guys know what pulse pressure is? John's nodding. What's pulse pressure, John? Oh, I thought you were doing it. Jacob, you heard of pulse pressure? You know what that is? It's just the systolic minus the diastolic pressure. That's a pulse pressure. Yeah, systolic, so if 120/80 is normal, pulse pressure then is going to be 40. Yeah, 40. Now, the Frank-Starling law is a feature of the heart that's intrinsic to the heart. And this comes from Otto Frank and Ernest Starling. And it essentially says the more you fill up the ventricle during diastole, the more forceful is contraction during systole. And this has been shown experimentally in rodent hearts, in dog hearts, in human hearts, in lots and lots of vertebrate hearts. This really holds and it's intrinsic to the heart itself. So this essentially shows you that as you increase contractility by sympathetic input, you're increasing venous return. So your EDV goes up. And as your EDV goes up, notice your stroke volume goes up because you're contracting more forcefully. Regardless of how much stimulation you're getting from the sympathetic nervous system. Here's why Frank Starling works. At rest, you have quite a bit of overlap between the light chains and the heart. So the myosin now can only bind, so this myosin here, it can bind to this light chain, but not that one, because the polarity is in the wrong direction. It's only when you stretch the muscle that you have more proportion of the myosin that can bind to the actin. So it's this structural feature of the sarcomeres of the heart that are different from what you see in muscle. Muscle, skeletal muscle. Do you have this at rest? No, no. As you stretch the cardiac muscle, you increase the proportion of the heavy chain that can now interact with the light chain. The more you have heavy chain interacting with light chain, the more force you can generate. So the greater the stretch, the greater the force of contraction. So this would be, remember, the M line. And you have these two essentially overlapping at the M line. You don't have that skeletal muscle. This is unique to cardiac muscle. Okay, contractility is just the strength of the contraction at a particular fiber length, which is pretty nicely illustrated here. And your sympathetic input, your catecholamines from the medulla of the adrenal gland, they're going to increase contraction strength. And you can see that here, relative tension without, with epinephrine, and this would be the case with skeletal muscle. And skeletal muscle, its contractility is not affected by tension, but if you overstretch muscle, skeletal muscle, now the ability of the myosin to be able to interact with the light chain, the actin on the light chain, the thin filaments rather, decrease. So you don't have as good strength. And the parasympathetic input, this means you better pay attention to this, does not affect contraction strength. So the effect is so-called chronotropic. It affects the rate. Parasympathetic only affects the only has a chronotropic effect, whereas cardiac muscle with epinephrine has an ionotropic effect. Your influx of cations increases because of the HCN channels. EDV goes up when venous return goes up. And we need to consider the things that influence venous return then. So, first of all, veins. Your deep veins from A and P. Where are the deep veins located relative to muscle? Right, they're like behind it, right? Behind it and the bone. So your legs especially, somewhat the arms too, but the veins of the arms, they go in, they go out. The deep veins of the leg, they stay deep. And when you walk, when you run, when you jump, when you play jump rope, when you know whatever, when you contract those big muscles of the legs, you're taking the veins and like a straw that you're trying to get the fluid out of, you're doing this to it. And that skeletal muscle pump drives blood from the lower extremities to the upper extremities. This is the reason why after surgery, the surgeon gets you up and forces you to walk right away. Because if you are bedridden for any length of time, blood in the lower extremity starts to pool. And when blood pools, it clots. Excuse me. its risk for clotting goes up. Let's be a little more accurate there. And those deep clots in the lower veins of the legs, that's called deep vein thrombosis. It's very dangerous. And it's due to a lack of this skeletal pump. Lack of this skeletal pump. Now, the other feature that can increase venous return is breathing. Because during inspiration, you create negative pressure in the thoracic cavity. So if you're running, you're pumping here, you're breathing hard here. This also will essentially move that blood very quickly up from the lower extremities into the heart, to a lesser extent, the upper extremities too, more the lower, but the upper too. Those are two things that increase your venous return. Big things that increase the venous return. So breathing, so increased blood volume will increase venous return. And breathing, and a skeletal pump, and then of course, vasoconstriction, that's due to alpha-1 receptors bound by epinephrine, norepinephrine as a result of the adrenal gland and the house that Jack built, whatever. Okay, veins. Veins. In physics, what is a capacitor? Anyone remember? Anybody doing any electrical work? What a capacitor is? Huh? So, no, capacitors usually are plates. They store charge. They store charge. You get a buildup of negative, positive charge, and you can complete that circuit by putting putting some sort of link over it that will essentially cause the charge to move and what have you. But that's a capacitor. The veins, they're capacitance vessels. They have high distendability because of their thin walls. This ability of the veins to respond to an increase in pressure by distending the walls so that you get increased volume of blood held within those vessels, that's called compliance. Compliance. Compliance can be calculated by taking the volume of blood, V, and dividing it by the pressure. And so compliance will be in milliliters divided by millimeters of mercury. If you plot the function, if you take blood volume versus pressure and plot it, you get a slope, and the slope of that line is a compliance. Veins have high compliance. Arteries have less high compliance. So 2/3 of the blood volume will be located in the veins. And so veins are called capacitance vessels. And you get a pressure drop, therefore, when you go from the arterial side to the venous side. Because of this increased compliance in elderly people, that compliance decreases. That's why elderly people will tend to struggle more with high blood pressure. And you can see here the distribution of blood in the systemic veins, small veins, venous, large veins. 70% of your blood is in those vessels. Capillaries, systemic arteries, heart, lungs, and you can see most of it's in the veins. So venous return is aided, first of all, by increased tone in the venous walls of the venous muscular, increased venous muscular tone due to sympathetic nerve activity. Also contractions of the skeletal muscles, particularly in the lower extremities, and then contractions of the diaphragm. You get negative pressure in the thoracic cavity, thus causing blood from the abdominal cavity to squirt up to the thoracic cavity to the heart. Get that difference in pressure. Very important. Okay. All right, now as we go from the capillaries, your blood, as you can see, is going to have a tendency to leak out, because remember, these particular endothelial cells, they fit together, but they have little holes. So you get fluid that's going to leak out into the interstitial fluid volume. Notice that most of your fluid volume's inside the cell. So blood, 3.5 liters. Interstitial, 11 to 13. Intracellular, 27 to 30. Yeah, most of your liquid is inside the cell. So on the venous side, you have high pressure that forces fluid. Your net filtration is higher, but your protein release will be minimal. That's due to charge issues. The protein is charged, can't get out very much, so the oncotic pressure of the blood goes up. On the venous side, pressure goes down, and the oncotic pressure of the blood is high. Now the tendency is for the fluid to return. And these are equations. You can see the pressure is high, your oncotic pressure, not such an issue. You have net filtration. You have a net filtration rate of about 11 torr. On the venous side, now your pressure is decreased. Oncotic pressure is a lot higher. And now you can see your filtration is minus 9 torr. Now you have net absorption. Where pi is your colloidal osmotic pressure, P is your hydrostatic pressure that's in the vessel, and then this is your colloidal pressure of the blood plasma. Now, some of this fluid doesn't go back all the way. That's going to be handled by the lymph. And so smart art here will show you this. Here is your arterial side, net hydrostatic pressure, net osmotic pressure. So 13, you have a filtration pressure of about 13. Then as you get to the venous side, now your pressure, you see, decreased pretty substantially. Before it was 33, now it's 13. Big difference. Now your net osmotic pressure is a lot higher. 13 minus 20 minus 7. Now your net, the net movement will be back into the vessel. You have a tenth of the fluid that doesn't go back in. 9/10 does. A tenth then will be picked up by the lymphatics. And this is very nicely illustrated in a little video that I have to show. Okay, whoa, 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 whoa. Let's get you, first of all, stop it. Let's get you over here, and let's help our folks. Okay, let's let them see this. All right, now we're ready to rock and roll. No buzz. Okay, stop share. Okay. Share. Yeah. Share. Good. Okay, and then there. All right. Now, what happens if you don't have that return from the lymphatic system back to the blood system? Well, from the lymph, if you clog up the lymph, you're going to have severe edema, severe swelling. And your book has this pretty, let's face it, disgusting picture of an individual with elephantiasis. In this case, repeated infection with filarial worms of the species either Wuchereria or Brugia clog the lymphatics, and you get this really, really, really severe edema. That, of course, is a very extreme case, but if you don't have proper working lymphatics, you can suffer from what's called pitting edema. Pitting because you put your finger into it and it doesn't go away. So if you have increased blood flow, increased pressure, you have increased filtration formed at the arterial end, there might be more pressure than you can recapture. That may lead to edema. You have increased tissue protein concentration, then that will decrease osmosis into the venous end. You'll get then edema. That's a sign of hypothyroidism. You have decreased plasma protein concentration. You don't have as much recapturing of the fluid. That will cause ascites in the GI tract, in the gut, and then obstruction due to these filarial worms or other types of lymphatic blockage can do the same thing. So the resistance to blood flow has to do not only with diameter, but also with length. With length, the greater the length, the greater the resistance. The shorter the length, the lower the resistance. The greater the diameter, the less the resistance. The smaller the diameter, the greater the resistance. And I don't want to belabor, the equations that you go through here. Suffice it to say, if you decrease the radius, you can, let's show it here. Yeah, you decrease the radius even a little bit, your resistance goes way up. As you can see here, comparing flow here to flow here, resistance here to resistance here. Yeah, that shows you how much resistance has an effect on, diameter has an effect on resistance. All right, we will pick this up then on Wednesday, finish it, and then get to the respiratory system.